My name is Bryce Sanford, and today we're going to be going over a case of non-bacterial thrombotic endocarditis. Objectives will be providing an overview of NBTE. We'll be reviewing a diagnostic approach and treatment options. We'll show the importance of multidisciplinary team approach with daily reevaluation and treatment options. For introduction, NBTE is a rare cardiac pathology that results from fibrin and platelet deposition on a cardiac valve. It's most commonly seen with advanced malignancy, predominantly adenocarcinomas, and the diagnosis is often made postmortem by means of autopsy. Those diagnosed prior to death may be discovered after an embolic event or in conjunction with valvular obstruction. Our patient was a 55-year-old woman who presented for an outpatient TTE with 3 weeks of cough, dyspnea, orthopnea, and peripheral edema. She had a history of stage 3C colon adenocarcinoma, status post-hemicolectomy, and 12 rounds of FOLFIRI FOLFOX. She had DVTs of the upper extremities and was on twice daily apixaban. The initial TTE showed severe LV dysfunction, global hypokinesis, and an ejection fraction of 26%. There was a large 1.6 by 1.3 millimeter echogenic fixed echo density on the aortic leaflets and severe aortic stenosis. Investigations consisted of an elevated BNP, troponin, and lactic acid. EKG showed sinus tachycardia, low precordial voltage, and a prolonged QT. White blood cell count was notably normal. The patient was admitted to the hospital, initiated on a heparin infusion, and cautiously diuresed given her preload dependence. During hospitalization, a transesophageal echocardiogram noted again global deposition up to 8 millimeters on all 3 AV leaflets, an echogenic mitral leaflet deposition, and a right atrial catheter-associated thrombus. Infectious workup, including blood cultures as well as serologies, were negative. The patient was started on guideline-directed medical therapy. Cardiothoracic surgery was consulted and recommended TAVR, but after 6 days of heparin, a repeat transthoracic echocardiogram showed improvement in valvular deposition, aortic stenosis, and systolic function. The patient was discharged home on indefinite enoxaparin therapy. She had a 2-month echo that showed normalization of the ejection fraction, improved appearance and metrics of the aortic valve, and a normal appearing mitral valve. For decision making, a lack of systemic symptoms and negative infectious workup led us to believe that the valvular structures were not infectious in origin. The valvular echo densities and metrics improved with the initiation of heparin infusion. This was consistent with NBTE. SAVR versus TAVR was discussed, but deferred because without treatment of her underlying adenocarcinoma, the deposition of the fibrin platelet material would likely recur on a new valve. The patient was discharged home on enoxaparin for systemic anticoagulation, as DOACs are deemed insufficient, and the use of warfarin in management of NBTE has unclear efficacy. Although one study has shown that patients in the setting of stroke with NBTE did have resolution of the fibrin deposition with warfarin. In conclusion, NBTE is a rare pathology associated with advanced malignancies. It is seen in 1.6% of all patients during autopsy, and although the diagnosis is primarily made postmortem, making the diagnosis while living can lead providers to provide a reversible therapy with heparin or enoxaparin. And as seen in our patient who developed NBTE on DOAC, DOACs are insufficient in the management of NBTE, so heparin should be used.